Welcome back to our channel, and today's topic is the Express Revision course for complete dentures as per your request. So today's video we are going to talk about the rapid revision course. This is Express Revision, wherein we are going to cover only high yielding points. We are not going to go through the details of complete denture, but we are going to go through the high yielding points which are required for competitive exam, can be your NEET PG exam. So without further ado, let's get started. But before we get started, make sure to subscribe to our channel before you get lost into the video, and also you can find some more interesting videos in the playlist. So once you YouTube the dental pathshala, you will find a playlist. In the playlist you have to go through the whole playlist where you will find more interesting videos. So today's topic is the topic of prosthodontics. So before get started with the complete dentures, let's see what is prosthodontics. Prosthodontics, whenever a patient comes to you in the department of prosthodontics, so we have got various departments in the dental college, right? So it is a dental specialty. It is a dental specialty. So this specialty, it covers the diagnosis. First of all, you diagnose the patient, then you treat the patient, then there is rehabilitation. That is, in the prostho we are going to restore, right? So rehabilitation and then the maintenance. So we are going to do the diagnosis, the treatment planning, the rehabilitation and the maintenance of oral function, comfort and also appearances. And more importantly, we see the restore the health of the patient, right? So the dental health of the patient. In the prostho, we see if there are any missing or deficient teeth, that is with the missing or the deficient teeth, and or the maxillofacial tissues, using biocompatible substitutes. So this is the definition of the prosthodontics according to GPT-8. It is a dental specialty pertaining to the diagnosis, treatment planning, rehabilitation and the maintenance of oral comfort, appearance, health of the patient with the missing or the deficient teeth and or maxillofacial tissues using the biocompatible substitutes. Also, what is CD? Now, complete denture is basically a prosthesis. It is a removable prosthesis that replaces the entire dentition, right? Because we are talking about complete here, complete. See, when we are talking about complete, this is a entire dentition, and when we are talking about the associated structures, the removable, it is the complete denture. So if we talk about what is a denture, denture is basically an artificial substitute of the missing natural teeth and their adjacent structures. So there are various steps in CDs. Steps in CD, that means we are going to give a denture, a complete denture to a patient, right? So there is no teeth which is present in the oral cavity. So we have got two kinds of steps. One is the clinical steps. One is the clinical step and the other one is the lab steps. Clinical steps are the steps which we do in the clinics, and the lab steps are the steps which we do in the lab, so in the dental lab. So clinical step, first of all, is our case history. The very first thing when the patient comes to you, we take the history of the patient, and that we are going to diagnose and that we are going to do the treatment planning. Then what we do is we prepare the diagnostic cast. So we prepare the diagnostic cast of the patient. Then we see that is there any requirement of mouth preparation, that is going to include the pre-prosthetic surgery. So if any surgery is required, suppose if any flabby tissue is there, any tori is present, so any surgery which we want to do before giving the denture to the patient, or in case there are deep undercuts which are present, we want to do the either alveoloplasty, alveolectomy. So any procedure, pre-prosthetic surgery will come under mouth preparation. Then we take the primary impression of the patient. And then after making the primary impression, we make the primary cast. Suppose in case you don't want to do, there is no requirement for any pre-prosthetic surgery, then directly our diagnostic cast will be our primary cast. So then we take the primary cast and we prepare the custom tray, right. Then we take the secondary impression. We'll be talking all these steps one by one, and then after taking the secondary impression, we prepare the master cast in the lab and we prepare the occlusal rims. And then we take jaw relation in the patient mouth and we do the teeth setting and articulation in the lab. Articulation and the teeth setting Then we do the trine. After we set the teeth in the articulator, then we do trine. And after that, we check the trine. After that, we do the processing of the denture. And then if everything is correct, there is denture insertion. And after insertion, we are going to recall the patient. Immediately after insertion, we give the post insertion instructions. And we are going to call the patient for follow up. Right. If any question is asked based on the clinical steps or based on the lab steps, now we know that which all are the clinical steps, which all are the lab steps. Now based on that, patient can be of four types. We can classify the patient according to the types of the mandible, the ridge of the mandible, the ridge morphology. So based on the mandibular height, based on the ridge morphology, based on the maxillomandibular relationship, and based on the muscle attachment. We classify the patient into four types. Class 1 is when the patient is having really good bone height in the mandible, so that is called as ideally, or the patient is minimally compromised. There is no compromise in the ridge of the patient. So basically what happens is the ridge is going to be really good, and we can say that this is an ideal denture, right. So the base height, mandible height is going to be greater than 21 millimeter. The maxillomandibular relationship is going to be class 1 maxillomandibular relationship. Then coming to class 2. Class 2 is the moderately compromised. Moderately compromised, wherein the height is not great but it's not bad either. So there is 16 to 20 millimeters, and again the relationship, maxillomandibular relationship, is class 1 in this case. So type 3 is substantially compromised. In that, the bone height of the mandible is 11 to 15 millimeter, and the type 4 is severely compromised. We are talking about severe resorption of the bone here. So severely compromised. So we have studied 4 kinds: severely compromised, substantially compromised, moderately compromised, and ideally compromised. So this is the types of the patient based on the mandibular height, based on the ridge morphology, based on the maxillomandibular relationship and the muscle attachment. We have got ideally minimally compromised, moderately compromised, substantially compromised, and severely compromised. So now we'll be talking about the case history. So we'll be covering only the high yielding points. Mental attitude of the patient is very important, because lot of time the question has been asked from the mental attitude of the patient. So in that we are going to cover the House classification. So in that we have got House classification, which was given in original House classification, which was given in 1950. Okay, so there are got again 4 types. The type 1 is the philosophical attitude of the patient. So we are talking about the patient attitude, the mental attitude of the patient. So the patient has got philosophical attitude. This is basically the ideal attitude of a patient, you can say. So this is the patient is cooperative for the procedure. So this is, we can say, the ideal attitude. And then the second one we have is the exacting. As the name suggests, exacting means the patient is going to tell you the treatment you should do. So he'll be talking about the treatment. So this is the exacting or the critical kind of patient. So basically what happens is, patient is going to find faults. He'll be complaining all the time. So find faults and complaining. The patient will be complaining all the times. The third we have is a hysterical kind of patient. So hysterical patient are, if you are doing, if they, if you make them happy, they are going to have a good attitude towards the treatment. But what happens, they have got some previous bad experience. So this is the hysterical or spectacle attitude of the patient. So they have got bad previous experience. Now one more thing I want to tell you, you don't have to note down each and everything. All the notes, whatever I am writing here, all the notes will be provided in the link in the description below. I'll provide you a link in the description below. So you have to visit a website wherein you will find all the notes. So whenever you want to revise anything, you will find link in the description below. So you will have to search for the link in the description and it will directly take away to the notes. And see, this complete denture express revision we cannot cover in one video because it is going to be lengthy. So we are going to cover in two parts. So this is the part 1 which we are going to cover. The part 2 will cover in the next video. So talking about the mental attitude of the patient, the philosophical is the ideal, exacting, critical, hysterical, and the fourth one is the indifferent. See, as the name suggests, I have been always telling you, you have to look for the name. Whenever you are reading the question, whenever you are attempting any question, first and very first thing is, most times 10 to 20% times the student, they know the answer but in a hurry they are doing it wrong, and sometimes when there is a negative marking, it goes in your negative. So indifferent patient, so you have to carefully read it. As the name suggests, see, the patient is going to have a different attitude. That means the patient doesn't want the treatment because of the family pressure. The patient is seeking the treatment, right? So that is the indifferent. So but all these classification which we have covered till now, the philosophical, exacting, hysterical, indifferent, all these type of attitude are based on the patient mind. And it couldn't give us the idea about the patient attitudes toward the dentist or towards the treatment procedure. So there is a revised classification which was given in 2003 by Gammer and Tuch. So this is a revised House classification. In that, we have got the ideal attitude, which is a really positive attitude. That means the patient is looking forward for the treatment, the patient is willing for the treatment. Next one is the submitter. That means, see, as the name suggests, that means the patient will come and surrender to you. So whatever you do, the patient is not going to open the mouth. So the patient is going to surrender to the dentist, and there is going to be the lack of discrimination. And also because since the patient is submitter, so there is going to be, they are going to be incapable of providing the genuine information. So next one we have got is the reluctant. As the name suggests, reluctant attitude is when the patient is not ready for any kind of treatment. The patient is denying the dental treatment. So that is the reluctant attitude. Again, we have got the indifferent. In the revised also we have ideal, we have indifferent. Indifferent is when the patient comes to you because of the family pressure, right? And he is indifferent to the dentist in a way that he is less engaged in the dental treatment. So the last one in the revised House is the resistant. Resistant patient will be spectacle to the dentist. Rather than cooperative, he will be giving challenges to the dentist. So he will not be willing for any kind of treatment. In fact, he'll be engaged in the treatment in a negative way. So he'll argue with the dentist. So that kind of attitude the patient will have. So guys, we have covered the House classification, the mental attitude of the patient. In that we have covered the philosophical. So the question which is asked is the ideal attitude of the patient is the philosophical attitude. Then we have got the exacting where the patient finds faults, then hysterical, then indifferent. Revised House classification, we have ideal, submitter, reluctant, indifferent and the resistance. Next, coming to the shape of the palatal vault. So how the palatal vault is, based on that is very important to know. You know why? Because the shape actually determines some various factor in the retention of the denture. Suppose if the patient is having U-shaped palatal vault. U-shaped palatal vault means the patient will have like this kind of palate. So this is the most favorable palatal vault of the patient. Then we have got the flat palatal vault. The flat palatal vault means, suppose this is the maxillary tuberosity and the palate is flat kind of. This is the flat palatal vault. So this palatal vault is going to resist the downward pull. So there is not going to be downward movement. There is going to be resistance to the downward pull. Resistance to the downward pull. But what happens in this case? There is going to be easy dislodgement. That means the denture, it can be dislodged by the rotational forces, by the lateral forces. So, but there is going to be dislodgement. Dislodged by lateral or rotational forces. Lateral or rotational forces. So, balancing is very important in case of a flat palatal vault. Balanced occlusion is very important. We have to give balanced occlusion. Next comes the third kind of palatal vault, which is the V-shaped palatal vault. V-shaped palatal vault is basically a high, narrow palatal vault. Like this palate is going to be so deep. So, this is the high narrow. And this is most unfavorable. Most unfavorable palatal vault for the retention. And what happens? See, this is the V-shaped palatal vault. This is a V-shaped palatal vault. If it is pressed against the sides, so the denture will loosen up and it will slip. So talking about, we have covered the shapes of the palatal vault. The U-shaped palatal vault is the most favorable and the V-shaped palatal vault is the least favorable. Least favorable. And if we talk about bony undercuts, we have got undercuts in the maxilla, then undercuts in the mandible, right? So undercuts in the maxilla, if they are present in the anterior ridge and lateral to the maxillary tuberosity, then we can relieve it in the denture. We don't have to go for the surgery. But in case in the maxilla, if there are severe bony undercuts which are present, then before giving the denture in the pre-prosthetic surgery, we need to remove it surgically. Okay, this is about the maxilla. Then talking about bony undercuts if are present in the mandible. Usually they are due to the sharp prominent mylohyoid ridges. Due to mylohyoid ridges, and it should be surgically corrected. So surgical correction should be done in case of mandibular bony undercuts which are present. Now talking about tori. Tori is a swelling which is bony swelling, I must say, which is present. It can be in the maxilla, it can be in the mandible. If it is present in the maxilla, then there is going to be presence in the midline. See, if you can see here, there is going to be present in the midline of the hard palate. And if you look at mandible, it is going to be present between 4 and 5. If you can see here, it is present between 4 and 5. 4 and 5. So it is going to be present in the premolar area. If you can see, this is in the maxilla, it is present in the middle of the hard palate, and in the mandible it is going to be present on the lingual side of the premolars, and which is a very important question which is frequently asked. So what happens? Always remember this. I am going to give you a very short trick. If the swelling is firm and bony, then we can keep it and use it as the primary support for the denture. So if the swelling is, again I am telling you, if the swelling is bony and firm, hard, then we can use for the primary support of the denture. If the swelling, we have to again relieve it during the denture by placing the lead tin foil during the processing. So, but we can keep it and use this, and we have talked about in the maxilla also, if you have seen, we have talked about relieving in the denture. So if there is undercut also which is present lateral to the maxillary tuberosity or in the anterior ridge, then we can relieve it. But if you have seen in the mandible, it has to be surgically corrected. Again the same goes for the mandible. If we are talking about in the mandible, it should be surgically removed. It should be surgically removed. So if any deep undercut is present, if there is going to be tori present, it should be surgically removed. There is no option of relieving in the mandible. You know why? Because it is sensitive to pressure. Because it is sensitive to pressure, so very slight amount of pressure also is going to cause pain to the patient, and therefore it is surgically removed in the pre-prosthetic surgery. That means before taking the impression, before starting the dental treatment, before starting the denture, we have to relieve it, and the surgical removal before the impression, especially when it is close to the floor of the mouth. So it should be surgically removed. And if we talk about how the tori looks like, so there is going to be the cancellous bone which is present, and it is surrounded by very thin cortical bone. So there is going to be the cancellous bone, which is surrounded by thin cortical bone. And the size, if you look at, so this is the tori. Now Size of a maxillary tori, it is small p size to huge size. And if we talk about size of the mandibular tori, then it is again small p to half hazelnut. But when it should be removed in the maxilla, mandible, we know that of course for sure it should be removed, surgically removed. There is no other way that we can relieve it in the denture, but when it should be removed in the maxilla and when it should be kept. So in the maxilla it should be removed, surgically removed, if it is extending, if it is extending till the PPS, posterior palatal seal area, or if it is interfering with the speech, or if it is causing poor denture stability. You don't have to take the notes, you will already, by the time you are watching the video, you will already find a link in the description box below wherein you will find all the notes. So you have to just go through the video and then you can look for the notes. So you have to remove it surgically if it is extending till the PPS, if it is interfering with the speech, or if it is causing the poor denture stability. If we talk about large tuberosities, if they are present, when it should be removed and when will it act as the primary stability, primary support to the maxilla. So we have got two cases, right? One is when it is removed. So if it is movable, it should be removed surgically. And if the large tuberosity is bony and firm, then we can use it for the stability of the denture. And if you see that, I have already told you this, that if the swelling is, if you have a look at, we are talking about the bony and firm will provide stability to the denture. We have already talked about this point. See, if the swelling is firm and bony, then it is going to provide the primary support. This point we have already talked about previously. If the swelling is firm and bony, it is going to provide the stability to the denture. So we have covered the undercuts, bony undercuts, the palatal shape of the palatal vault, and the tori. When it should be removed, when it is going to give the support to the denture. So talking about the anatomical landmarks for maxilla. We have got stress bearing areas, primary and secondary. There are two stress bearing areas, the primary stress bearing areas and the secondary stress bearing areas, right? So the primary stress bearing areas are all the slopes. I am talking about the shortcut here. So you will find all the slopes. Why do we call it the primary stress bearing area? Why are we differentiating the stress bearing area into primary and secondary? So if we talk about primary stress bearing area, there is going to be least resorption. Okay. And what are the primary stress bearing areas? These are the horizontal slopes of hard palate and the posterior lateral slopes of the residual ridge. Right. Talking about secondary stress bearing areas. Secondary stress bearing areas, we have got the crest of the ridge. Let's use another color. So secondary stress bearing area is the crest of the residual ridge. Then we have got rugae. Now again the question can be asked, they can directly ask you which of the following is not a secondary stress bearing area. So there are three secondary stress bearing areas: the crest of the residual ridge. See, the crest of the residual ridge for maxilla is a stress bearing area. Crest of the ridge for mandible is a relief area. You have to remember this, always remember this. See, the crest of the ridge, residual ridge, is a secondary stress bearing area for the maxilla. For the mandible, when we are going to talk about, it is the relief area. So the crest of the ridge, rugae as well as the maxillary tuberosity are the secondary stress bearing area. Crest of the ridge, why crest of the ridge is stress bearing area in case of maxilla? Because it provides good support, but again it undergoes resorption. If we talk about the primary stress bearing areas, they have got least resorption, right? But if we talk about the secondary stress bearing areas, then the secondary stress bearing areas, there is going to be some resorption, but not that amount that we have to relieve it. So there are going to be three secondary stress bearing areas: the crest of the ridge, the rugae and the maxillary tuberosity, right? Then we have got the supporting structures. Then there are supporting structures. I hope that you guys already know this is the, if you can see here in the diagram J, the pink color one is the crest of the ridge. Then we have got rugae in the H. Then we have got maxillary tuberosity. As you can see, the maxillary tuberosity is in the A, right? The yellow color one, this one. Okay. Now, the supporting areas are the areas which are going to give the support, right? So the supporting areas is the hard palate, rugae are also supporting areas. Then we have got the posterior lateral slopes. See, posterior lateral slopes again is the supporting area, and then we have got the maxillary tuberosity. So these are the supporting areas. Then very important is the relief areas. Relief areas, we have got three relief areas in the maxilla: incisive papilla. Why incisive papilla is a relieving area? Because it has got nasopalatine. See, now pattern nowadays has changed. They are asking the reasoning kind of questions. Nasopalatine nerves and vessels. So if we don't relieve it, so there is going to be the pain and burning sensation the patient will complain of. We are going to cover in the problems in the end of complete denture. So we have got the cuspid eminence, that is the canine area, and these relief area, if you have done the complete denture, then you must have placed wax spacer. So all the area in the selective impression technique, we are going to relieve with the help of a wax spacer. So all these are the relief areas. And the mid palatine raphe, where there is going to be the median sutural area, palatine raphe, because there is a thin mucosa, so that is most sensitive area. So the another question Okay, frenum we are going to cover in the end. Talking about the mandible. In the mandible, we have got the supporting areas. Supporting areas, we have got two supporting areas. The buccal shelf area. See, buccal shelf area in the mandible, again we are going to cover it one by one in detail. So, the buccal shelf area is the primary stress bearing area, you can say, for the mandible. Buccal shelf area is this one in the pink. So, this is the buccal shelf area. Then we have got the residual ridge. This is not the crest of the ridge. The crest of the ridge is again a relief area. Residual ridge, you have to read it carefully. If the question is residual ridge, then it is a supporting area. But when there is a crest of the ridge, when the option is the crest of the ridge, crest of the ridge, crest of the residual ridge, then it is going to be a relief area. Okay. So, if the option is, if the question is asked from the relief areas, then if all of the following are the relief area except, and if in the option this a residual ridge is given, then you have to mark residual ridge, because residual ridge is a supporting area. Relief area, we have got the crest of the ridge here. Crest of the ridge, then we have mental foramen, then the genial tubercle, tori in the mandible, which we call it torus mandibularis. In the maxilla, the torus we call it mandibularis. Tori we have already covered, my lovely students. See, tori we have already covered in the maxilla and in the mandible. Okay. So, relief area. Then coming to limiting structures of the mandible. See, now we have not covered limiting structures of the maxilla till now, right? Maxilla we have covered the stress bearing area, supporting areas and the relief areas. So, if we talk about relief areas, for maxilla it is incisive papilla, cuspid eminence and mid palatine raphe. Now talking about the limiting structures. Limiting structures for maxilla, for mandible and for both maxilla, mandible. First of all, common structures I am going to write. So, that is the labial vestibule, labial frenum, starting from labial frenum, then we have got labial vestibule, then buccal frenum, buccal vestibule, then in the maxilla we have got hamular notch. We have got fovea palatine and we have got PPS area. In the mandible, one more frenum is extra, which is present in the lingual area right here. So, that is our lingual frenum. Lingual frenum. Then we have got alveolingual sulcus. Then there is a retromolar pad, this one white one is the retromolar pad area. And the pterygomandibular raphe. Again, pterygomandibular raphe is also limiting structures, don't get confused. Pterygomandibular raphe. Now, there is one more question which is frequently asked, which is the number of frenum which are present in maxilla. So, now we are going to write the number of frenum. in the maxilla and in the mandible. So, in the maxilla, if you count, have a look, we have got one here, buccal E, right? Then we have got here one C and one we have got here, which is our I. So, we have got 3 frenum in the maxilla, which is maxilla we have got 3, right? 1 in the labial and 2 in the buccal. 1 in the labial and 2 in the buccal. If we talk about mandible, we have got 1 labial, 2 buccal and we have got 1 lingual also, the lingual frenum. So, there are 4 in the mandible. So, 1 in the labial, 2 in the buccal and 1 in the lingual. So, number of freni is also asked. So, we have covered. Now, we will be covering one by one all the anatomical landmarks. I wish you well for your NEET exam, and you are intelligent, you can do this, you have the potential to do it, you are hardworking. How do I know? Instead of watching entertainment videos, you choose to invest your time in learning and studying with us. So, without wasting much time, let us get back to the topic. So, talking about the maxilla. Now, the ultimate support for maxillary denture, is from the palatine bone, which is the palate, and the palatine process. Of the maxilla, right? Of course, palatine process is present in the maxilla. So, the support, ultimate support for the maxillary denture is from the palatine bone and the palatal bone and the palatine process of the maxilla. Talking about buccal frenum in the maxilla. So, the buccal frenum, we have to learn the muscle attachments for the buccal frenum. So, the buccal frenum is, see, buccal frenum we need to we need to clear the buccal frenum, because there are muscle attachment to the buccal frenum. So, there are 3 muscles attachment which we will be studying, which is the levator anguli oris, which is going to attach beneath the frenum, the orbicularis oris, which is all over the mouth, which pulls the frenum forward, and the buccinator, which is going to pull the frenum in the backward direction. So, the levator anguli oris is going to attach beneath the frenum. Then the orbicularis oris is going to pull the frenum in the forward direction, okay, in the forward direction, and the buccinator is going to pull the frenum in the backward direction. So, how do we learn it? See, forward R, orbicularis oris, then we have got buccinator B, which is the backward. So, we can learn it orbicularis oris forward and buccinator backward. Then we are going to talk about the hamular notch. As you can see, the hamular notches are in the K here. They are behind the maxillary tuberosity, and the hamular notch and the hamular notch are basically, as you can see, they are the soft tissue depressions. So, there is going to be depression. What is the meaning of a notch? Basically, notch means the depression, right? So, they are the depression between the distal surface of the maxillary tuberosity. Once I erase it, you can see here. See, they are present in the distal surface of the maxillary tuberosity and the hamulus of the pterygoid plate. So hamular notch is present between the distal surface of the tuberosity and the hamulus of the medial pterygoid plate. The most important thing about hamular notch is that it is going to mark the posterior border of the maxillary denture. Posterior border of the maxillary denture. So this is going to be a center of the deepest point, center or part of the deepest part of the notch we mark as the posterior palatal seal area. So this particular fellow is our hamular notch, which is labeled as K. So this is the hamular notch. Next one we have is the fovea palatini. Fovea palatini, if you see here, fovea palatini are marked as L. These two white dots. So in the palate, suppose here there are two mucosal gland openings. So fovea palatini are the mucosal gland openings posterior to the hard palate. They are posterior to the hard palate and they are not found in every individual. They are not present in every individual, okay. And denture should extend beyond the, see, denture should extend beyond the 1 to 2 millimeters to the fovea palatini. Now, if you forget it, you can see here, denture is going to extend 1 to 2 millimeter beyond the fovea palatini. If you can look here, fovea palatini, they are prior to the posterior palatal seal area. This is the posterior palatal seal area and they are 1 to 2 millimeters. They are 1 to 2 millimeters beyond the, a denture should extend beyond the fovea palatini and they are only used as guideline for PPS. Used as guideline for PPS placement. So they are present on the soft palate 2 millimeters behind the vibrating line. On the soft palate 2 millimeters behind the vibrating line. Right. So these are basically mucosal gland openings and denture should extend. This is the distal border of the denture. So the distal border should extend behind the fovea palatini, not up front of the fovea palatini, but behind the fovea palatini. So we have covered hamular notch, fovea palatini. Now talking about the soft palate. Soft palate, the classification is very important for competitive exam point of view, and the classification was given by Again House. So the classification was given by House. So I am going to draw here. This is type 1. Okay, this one is type 1. So this is the junction of the hard and the soft palate. I'm going to draw right here junction of hard palate and soft palate. Okay, this is type 1. Type 1 wherein we have got more than 5 millimeter. So we have got more than 5 millimeter area for the retention. So the tissue availability, I must say, for the post dam. Now post damming is our PPS, again is also known as post damming. So this is ideal for the retention of the denture. So if there is going to be presence of the soft palate type 1, then this is the ideal for the retention of the denture. Then second one we have is the when the soft palate is going like this, okay, and the area available or the tissue available for PPS or the post damming is between 1 to 5 millimeter. So the tissue availability for the post damming is 1 to 5 millimeters, and the type 3 we have is when the palate is like this, and the tissue availability is very less. It is less than 1 millimeter. So if the tissue availability is less than 1 millimeter, which is, I'm so sorry guys, which is poor for the retention. Which is poor for the retention of the denture. So the ideal is the type 1 or the class 1 soft palate. Class 2 is 1 to 5 millimeter of tissue availability. Class 3 is when there is less than 1 millimeter of tissue availability. This is one classification. The another classification I can write is when there is going to be horizontal or little muscular movement. That means the more area is covered. If you see here, okay, now you can make out, right? So if there is going to be more tissue coverage, then it is a type 1 because more than 5 millimeter of the area tissue is available for the post damming. So if it is okay if I say this is the widest PPS is recorded in case of class 1. Then we have got the class 2 wherein the soft palate is at an angle of somewhere around 45 degrees to the hard palate. If I say that in class 3 it is somewhere around 70 degrees to the hard palate. So class 3 is seen in the V-shaped palatal vault. V-shaped palatal vault. Now the amount of posterior tissue, the amount of tissue which is available for post damming, which I have highlighted here, this area, right? This area, 5 millimeter, more than 5 millimeter in class 1, 1 to 5 millimeter in class 2, and class 3 it is less than 5 millimeter. Amount of posterior tissue will give us the PPS area. So the amount of posterior tissue, which is for class 1 it is more than 5 millimeter, for class 2 it is 1 to 5 millimeter, and for class 3 is less than 1 millimeter, will give us PPS area. And more the PPS area, we know that more the PPS area, more will be the retention of the denture. So that's why there is going to be the most retentive soft palate is the class 1 palate for the maxillary denture. So talking about the posterior palatal seal area. Posterior palatal seal area, we also know it post damming. So this is basically the junction, it is a soft tissue along the junction of the hard and the soft palate, on which we can apply pressure within the physiological limit to aid in the retention of the denture. So very important point here in the PPS is, see, PPS, posterior palatal seal area, this is the posterior palatal seal area, right? So this PPS area, first of all, it is present on the soft tissue, right? Then it is present at the junction of the hard and the soft palate, hard palate and the soft palate. Then on which we can apply pressure, because once we study the PPS technique of recording PPS, we are going to trim the cast. So we are going to put little extra resin over there. So that means we can apply pressure, on which pressure can be applied within the physiologic limit. This is very important, can be applied within the physiologic limit to aid in the I'm so sorry guys, again, to aid in the retention of the denture. In the retention of the denture. Now this aid in the retention of the denture is very important, because there are so many functions for PPS, but all the options which are given to you are an example of the function of the PPS, but the most important function over here is the retention of the denture. So retention of the denture is the most important function of the PPS. Now talking about the PPS again, posterior palatal seal area, it is a combination of two things. One is the post palatal seal plus it is pterygomaxillary seal. Let's write it with other color, plus pterygomaxillary notch, or I can say hamular notch. So this is the pterygo, this particular is our pterygomaxillary seal. Okay, and this guy over here is our post palatal seal. So this is the post palatal seal. This particular is our pterygomaxillary seal. So PPS is a combination of post palatal seal and pterygomaxillary seal, or pterygomaxillary notch or hamular notch seal. I can also write the seal. Here we have got palatoglossus muscle. So let's draw above which we have got the hard palate and the soft palate. Suppose this is the hard palate. Here is the hard palate, and this particular fellow is our soft palate. So this is the soft palate, this is the hard palate, this is the hard palate. Now we have got the soft palate over here. Okay, this is the soft palate. Now from the soft palate, the muscle which is going to the tongue is the palatoglossus. Glossus means tongue, palate means from the palate. So arising from the palate, going to the tongue is the palatoglossus. Then we have got up in the cranium base, we have got tensor veli palatini, and on the other side we have got the levator veli palatini. See, all this we will be covering in the anatomy also. So I just want you to remember that tensor veli palatini, this is the tensor veli palatini. which is the most important muscle of the soft palate, as it forms the palatine aponeurosis. So the tensor veli palatini, which is arising from the eustachian tube from the base of the skull, attaching the soft palate, is it marks the posterior vibrating line. So at the junction of the aponeurosis of tensor veli palatini and the muscular portion of the soft palate. So posterior vibrating line, very important, posterior vibrating line marks the most distal extension of the denture base. So if the question is asked, what marks the most distal extension of the denture base? Anterior PPS is given, anterior vibrating line is given, posterior vibrating line is given. So you have to mark the posterior vibrating line as it marks the most distal extension of the denture base. Now what are the functions of posterior palatal seal area, or we can say post dam? What is the significance? What is the function? So very important function is to aid in the retention. All the options will be given, but if retention is given, you have to mark retention of the denture. Also it reduces the gag reflex, as there is going to be no gap between the denture base and the soft palate. So the denture base and the soft palate, that means the PPS is so adapted well that there is going to be no space between the denture and the tissues. So there is going to be reduced food accumulation. So food cannot go inside because there is no space, right? So that also will result in patient discomfort. So reduced patient discomfort. As the posterior end is closely bound to the soft palate tissues, so also what happens when we are using the methyl methacrylate, the acrylic resin, there is going to be shrinkage during the polymerization of the acrylic resin, and since we have marked the PPS, we have made the PPS in the denture, so whenever there is going to be polymerization shrinkage, volumetric shrinkage from the resin, so that will be compensated by the PPS. So it also compensates for the volumetric shrinkage. During the polymerization of the resin. Methyl methacrylate. Okay, and it creates a seal, a vacuum between the denture and the tissues, and most importantly it aids in the retention of the denture, which is very important function of the PPS. So the most important function, the most common function is the retention of the denture. So whenever we are recording the PPS, so while recording the PPS, or we can say post dam, right? So the patient head should be tilted. Now imagine, see, why are we recording this PPS? So that there is no food which is accumulated between the tissues and the denture, right? So when the patient is eating, the food should not go from behind up in the denture and the tissues. So we want denture to be retentive when the patient is in its function. So we want the denture should not come out when the patient is eating food. How do we eat food? Does our mouth is parallel to the floor? No, we slightly bend our head down. So whenever we are eating food, we don't eat like this straight, right? We don't eat like this. What do? We slightly bend our mouth like this, right? While we are eating food. So we slightly bend it. So the head should be tilted. Like you have to just, now you are listening to the lecture, you are sitting, you have to just Imagine that food is in your hand and you are trying to eat. You are going to slightly bend your head down. So that is how the PPS should be recorded. So the patient head should be tilted downwards like how we eat by the 30 degrees. So this is very important point, that how we record the PPS. While recording the PPS, the head should be tilted downward by 30 degrees. So there is going to be tilting of the head, right? What are the techniques of recording the PPS? So we have got 3 techniques. One is the conventional technique. So the first one is the conventional technique. Another one is the fluid wax technique. And the third one is the arbitrary scraping of the master cast. Arbitrary scraping of the master cast. So the 3 technique is the conventional technique, the fluid wax, arbitrary scraping of the master cast. We also call it empirical method. So talking about the conventional approach. Conventional approach is via an instrument known as T-burnisher. So as you can see, this is a T-burnisher. Okay, and it has got 2 ends. One is with a ball. So this is the ball end of the T-burnisher. So we take a ball end of the T-burnisher, we go posterior to the tuberosity, and until we feel a drop. Now let's have a look at here. This is the maxillary tuberosity, right? This whole area. So what we do is, we take the T-burnisher, the ball end, and we go posterior. Ball end should be buccally. See, this ball end of the T-burnisher, it should be buccally, and the other straight end should be palatally. So we take the ball end of the T-burnisher and we feel this drop, this hamular notch drop, because notch, there is a depression, right? So we feel this depression and we mark it until we feel a. First of all, we take the T-burnisher, this ball end, towards the buccal. See, for B for ball and B for buccal. You can also remember it this way. So B for ball and B for buccal. So we mark a line with the indelible pencil. So with the T-burnisher, we mark the line. Mark the line using an indelible pencil. Indelible pencil is a pencil which runs on the skin, mucosa. So we use this pencil to mark, and through the notch, extending 3 to 4 millimeters anterior lateral to the tuberosity, approximating the mucogingival junction. And then we ask the patient to say ah in the short unexaggerated manner, and we then mark the posterior vibrating line. Then we connect both the lines, anterior vibrating, posterior vibrating. Then we do the scraping of the master cast. Scraping of the cast. How do we do scraping? Suppose this is the posterior vibrating line, right? So in the posterior vibrating line, we go 1, 2, 3 from the midline. This is posterior vibrating line. From in the middle, this is the middle suppose. In the middle, we go 1/3 in the deepest part, and then we scrape 1 to 1.5 millimeter. Okay, and in the mid palatine raphe, area, we cannot put more pressure in the mid palatine because we have already studied that mid palatine raphe is a relief area. So it's basically a relief area. We cannot go much deep, we cannot put more pressure. So in the mid palatine area, we scrape 0.5 to 1 millimeter. This is the conventional approach. Then talking about the second one we have is the fluid wax technique, also known as physiologic method, also known as functional method. Why physiologic method? Because this is a physiologic technique of displacing the tissues within the physiological limits. Why functional method? Because we are going to take the mouth temperature waxes. Mouth temperature waxes to record the PPS. What are the waxes which we use? You can write WO. So white color wax is the Iowa wax. Okay, O is the orange color, which is our correcta, wax number 4. So all these questions can be asked. Which of the following is a mouth temperature wax? Which of the following is not a mouth temperature wax? Yellow white color is HL physiologic paste. Okay, so fluid wax technique, in the PPS area we are going to put the wax and the mouth temperature waxes, which will be flowable at the room temperature, but they are going to set inside the mouth. So the white, wow, you can remember W, Iowa white, O orange, correcta orange, O is there, yellow, and then physiologic paste. So these all three are the mouth temperature waxes which are very important, which can be asked in the exam. Now the glossy, if the area is glossy, that means there is going to be tissue contact. Now you need to remember one more thing. When we are doing the border molding, if there is going to be the glossy area, that means there is no tissue contact. But if we are talking about wax in here, wax, I am going to write wax. Glossy, if it is dull area, then there is no tissue contact. Okay. And if we talk about in the border molding, we take green stick, right? Low fusing. Green stick. It is opposite. That means glossy area in the green stick will not record the tissue, and dull area will record. That means if the area is dull, opposite to wax. That means if the area is dull, there is no tissue contact. And if the area is glossy, if the area is dull, that means there is going to be tissue contact. If the area is glossy, there is no tissue contact. For green stick, this is for green stick. This is for green stick, low fusing. This one, glossy area tissue contact, is for waxes. So you need to remember both of these points as well. Okay. Next one, third one we have is the arbitrary scraping of the master cast. Or we can say empirical method. There are so many authors which have given their own scraping width and depths. Okay. So we are going to talk about now arbitrary scraping of the master cast. If we look at the three methods: conventional method, the fluid wax and the arbitrary scraping of the master cast. This arbitrary scraping of the master cast is actually the least acceptable method out of all three. The three are conventional method, the fluid wax technique and arbitrary scraping of the master cast. And once you see, suppose this is the maxillary ridge, this is also maxillary ridge, okay. This one is our anterior vibrating line and this is our posterior vibrating line. Now we are going to talk about width, how much we are going to scrape from the cast, and here we are going to talk about the depth, both in the millimeters. If they are asking the depth, if they are asking the width, okay. Depth, we know that depth means we are going inside in the tissues, we are scraping the master cast from the deep inside. So when we are talking about depth, that means we cannot go in the mid palatine raphe area because that is the relief area. So the depth in the mid palatine raphe is going to be the least. Then from least we are going to the max for the depth. So here 1, then 2 and then 5 in the hamular area, then 2 and 5. If we are talking about width here, this was the depth. Now we are talking about width here, okay. Width we have, now width we cannot take, see here in the hamular area the width is low and here the width is maximum, right. So the lowest is going to be here 2 and 2, let's write 2. Then we have got 6 maximum and then in the middle is 4. So this is the width in the millimeters. Now guys, this is the ridge and this particular fellow is our posterior palatal area. Okay, this is the PPS area. Now scraping of the master cast, width, if we are going width wise, then least in the hamular area. If we are going depth wise, that means inside how much we are scraping into the depth, that means least in the mid palatine area because mid palatine raphe is the relief area. Now this is recording the PPS. We have covered recording the PPS, 3 methods we have covered: the conventional, the fluid wax and the arbitrary scraping of the master cast, which is least acceptable. Conventional we are using the T burnisher. Fluid wax we are using the mouth temperature waxes to record the PPS, and then arbitrary scraping of the master cast wherein we are going to scrape the master cast. Now talking about improper PPS. Improper PPS. It can be the extension, that means we have overextended the denture, that means we have gone beyond the PPS area, that is the extension. Or if suppose if there is overextension, that means we have gone behind or beyond the posterior vibrating line, that means overextended. And if we are talking about underextended, that means we have come close to fovea palatini. We have already talked about fovea palatini. After fovea palatini there should be minimum of somewhere around 1 to 2 millimeters. Then the another one is the post dam, that means how much we have scraped. That means if we have scraped more means we have scraped the master cast more, that means there is going to be lot of tissue compression because we have increased the area of the PPS, right. So under extension again we have got under and over. That means suppose if this is a denture, okay, Suppose if this is the denture of the patient. Okay, this is the denture. Overextended means I have extended beyond the PPS. Underextension means I have marked behind the PPS. Post damming means we are talking about thickness over here. Suppose this is the tissue surface of the denture, this is the polished surface of the denture. So this is the PPS, right? So this is the tissue surface and this is the polished surface. Okay. Now, if there is going to be the over post damming, that means I have compressed the tissue more. Under means there is going to be less of the tissue compression. So this is over and this particular guy is under. This is extension and this is post dam, right? So post damming also, under post damming and over post damming, right? So first one by one we will cover. First of all we are going to cover extension. So under extension, that means the denture, the distal extension of the denture is behind, it is above the posterior vibrating line. That means we are using, this happens when we are using the fovea palatini as a landmark. Okay. And suppose when you are taking impression and then patient is having gag reflex. So because of that, the denture trial basis you have trimmed it. So that means you have shortened the length because underextended, this is underextended, okay. That means because of the gagging of the patient, you have shortened the distal border of the denture. So that is going to be gagging of the patient. Gagging means the patient is having the feeling of vomiting while recording, right? And the most common failure of the seal of denture is due to underextension. That means when the seal fails, that means if the upper denture is not retentive, it is falling down again and again. So causing of the failure of seal. That means there is not going to be a retentive maxillary denture, there is going to be failure in the breakage in the seal, is due to the underextension of our denture. So right. So this is about the underextension, the cause of the failure of seal. Now talking about overextension. Overextension means you have overextended the distal surface of the denture. That means not whole of the denture will not be overextended. There are going to be some areas we are talking about. Some areas are going to be overextended, and see, very important point is pterygoid hamulus should never ever be covered by denture. Should not never be covered by denture. Never be covered. If it is covered, then the patient, if covered, then the patient will complain of pain during function, and also patient will complain of difficulty in swallowing. Right. So there are two scenarios. One is when the denture is underextended, another one is when the denture is overextended. So extension part is done. Now talking about the post damming. So post damming is when there is going to be under post damming. When there is under post damming. So under post damming means we have not scraped enough the master cast. We have scraped the master cast less. So what happens when the patient opens the mouth wide? So wide open mouth, we take impression. So there is going to be the stretching of the pterygomandibular fold. Wide open mouth. And how do we check this under post damming? Post damming is PPS. Okay, under post damming is the PPS is not marked properly. That means the scraping of master cast is less. See, post damming, that means this is the arbitrary scraping of the master cast. If we have not, instead of going depth, we are talking about under means depth is less. That means if we are supposed to scrape 2 millimeters and 5 millimeter, 1 millimeter like that, and we have scraped it very less. Where we are supposed to go by 2 millimeters, we are not going 2 millimeters, we are going 0.5 millimeter like that. Okay. So under post damming, how do we check? We take a wet denture, we place in the mouth, we slowly firmly press it from the mid palatine raphe, and if you see any bubbles escaping beneath the denture, then the denture is under post dam. That means checked with wet denture. And if we see bubbles, if bubbles escaping or coming out of the denture, that means under post damming is there. And how do we correct it? Correction. We scrape the master cast more. Scraping the master cast. And using the fluid wax technique. But patient should not open the mouth wide. Fluid wax technique. Okay. Talking about the fourth one, which is our over post damming. So over post damming is when there is too much scraping of the master cast, right? Too much scraping of the master cast. See, when there is too much scraping, there is post damming. When there is moderate scraping, what will happen? Then there is going to be the tissue irritation. Tissue irritation. And one more thing I want to tell you. If there is too much scraping of the master cast, it is going to displace too much of the tissue, especially in the pterygomaxillary seal area. So because of that, there is going to be displacement of too much of the tissue. Because we have scraped it more, then there is a compression of the tissue more. So there is going to be the displacement of too much tissues. And especially which tissue we are talking about here is the pterygomaxillary seal. We have already covered two parts of the PPS. One is the pterygomaxillary seal. If you can see here, we have covered the two parts of the PPS. One is the post-palatal seal and one is the pterygomaxillary seal. So too much scraping is there at the pterygomaxillary seal, and if you remember pterygomaxillary seal, the scraping we are doing is 5 millimeters, and if we are going more than 5 millimeters, then there is going to be over post damming. So how do we correct it? We reduce the area slightly. Correction, how do we do it? We reduce the area slightly, because there is going to be thickness of the denture. if there is, see, if there is depression, more marked depression here, we have scraped too much, that means the denture base in this region is going to be thicker. So what do? We want to insert less pressure on the tissues. So therefore we are reducing the area slightly and then slightly polish and pumice it. What happens if we place PPS too deeply? It will result in displacement of the denture anteriorly. Denture anteriorly. Okay. So we have covered, if the PPS is too deeply covered, there is going to be displacement of the denture anteriorly. Over post damming is too much scraping. Under is less scraping. Let me write once again. Is under scraping. Under scraping. Okay. Then we have studied extensions, the fovea palatini we use as landmark. Then we have under extended it, that is the main cause of the failure of the seal of the denture. Very important for exam viewpoint. See, now you have to understand it. Improper PPS can be extension, can be post damming, right? So it can be extension, it can be post damming. Extension is when there is under extension and over extension. Post damming is under post damming, over post damming, right? Then we have got under extended, most common failure. Over extended, when we have gone beyond the PPS. Let me write it, when we have gone beyond the posterior vibrating line. Okay. So talking about the mandible. Mandible, we have already covered the supporting areas. What are the supporting areas in the mandible? Very important. Supporting areas of the mandible are very important. We have covered buccal shelf area, or in the option, if buccal shelf area is not given, if there is external oblique ridge given. Right. So buccal shelf area, we know that this particular area is the buccal shelf area. Okay. As you can see here, this is the buccal shelf area. So the buccal shelf area is between the buccal frenum. As you can see here, it is between the buccal frenum and between the anterior border of the masseter muscle. So the buccal shelf area. Now this is a supporting structure. That means there is going to be, we can put pressures on it, right? So there is going to be increase, all other rest, most of the things will decrease in size when there is a resorption of the ridge. Mandibular resorption, we know that mandible there is more resorption, right? So buccal shelf area is increased in resorption. It is so surprising that mostly what happens is, with the increase in the resorption, rest of the things shrunken down, right? But increase in the resorption, there is going to be increase in the buccal shelf area. So buccal shelf area is the supporting area. It is going to take up all the loads, take up all the occlusal forces, because it lies perpendicular to the occlusal forces. And if we talk about average mandible, it is 4 to 6 millimeters. And if we talk about narrow mandible, then it is 2 to 3 millimeter wide. So there is going to be large nutrient canals present, intact cortical plate, and also one more thing I would like to add is the buccinator muscle. Buccinator muscle, whenever we are talking about buccal areas, we will be talking about the buccinator muscle. So you can remember B for buccal, B for BUCC, buccinator. Now, because of the muscle attachment, there is reduced resorption, and this is the reason that it is a supporting area, because there is going to be muscle attachment, and because of that there is going to be less resorption. But when ridge is flat, when the crest of the ridge is almost flat, then the buccinator, then this buccal shelf area is almost attached to the crest of the ridge. That means buccinator is almost attached to the crest of the ridge. But you will be telling, ma'am, buccinator muscle is attached to the buccal shelf area, then why are we covering it? Because this muscle is inactive, therefore we can cover it by the denture. Okay, so this is about the buccal shelf area. And if we talk about the buccal shelf area, this, if you can see here, let me again draw it. See, this is the buccal shelf area. Okay, okay, let's see, this is the ridge. I am drawing it from this side. This is the ridge. This particular area is the buccal shelf area, right here. As you can see here, we have zoomed in this section. This is the buccal shelf area. Now, buccal shelf area is surrounded mesially by the ridge, crest of the ridge, okay, laterally by the external oblique ridge, you don't have to write this, externally by the medially by the ridge, crest of the ridge, then distally. That means we are talking about, if this is the buccal shelf area, distally there is going to be the presence of retromolar pad. As you can see, distal there is going to be retromolar pad. So, distal to buccal shelf area, there is going to be retromolar pad. As you can see here, distal to it is the retromolar pad, which is the pear shaped pad. Then laterally we have got external oblique ridge. Okay. Second one, this is the first supporting area. The second supporting area we have is the residual alveolar ridge. Right. Crest of the ridge in the mandible is a relief area. Crest of the ridge in the maxillary is a supporting as well as it is a secondary stress bearing area, right. So, now talking about the relief areas. Relief areas. Relief areas we have got crest of the ridge. We have already covered this. Mental foramen, genial tubercle, and tori and torus mandibularis. Now we have covered that. Tori, if present in the maxilla, torus platanus is can be relieved by the denture, by the tinfoil spacer, or can be surgically removed. But tori in the mandible, it should be surgically removed. Before starting with the impression procedure, surgically removed, right. Now, external oblique ridge, if in the option external supporting areas question has been asked and there is going to be the external oblique ridge also given, then external oblique ridge can be also act as a supporting area. This is a smooth ridge which is present on the buccal surface, which is extending from the anterior border of the ramus and forward till the foramen area. Now talking about the limiting structures in the mandible. So, limiting structures. We have got the labial frenum. Labial frenum is present in the maxilla as well as in the mandible also. So, labial frenum is same as the maxilla, but here it is active. So labial frenum is active in case of mandible. Okay, limiting structures, let me write mandible. Okay. Then there is going to be the muscle attachment, which is orbicularis oris. Orbicularis oris. Also there can be insidious muscle. Now this labial frenum, it is sensitive, it is active, and it get narrowed. That means decrease in the size when the patient opens the mouth. So it get narrowed on wide opening, right. Then there is a lingual frenum which is present in the lingual area. Then we have got the retromolar pad, which is very important, which is a pear shaped pad. So retromolar pad, as you can see here, it is a pear shaped pad, pear shaped, like this. This is our retromolar pad, so which is known as pear shaped pad because the shape is pear. Now this pear shaped pad name was given by Craddock. Retromolar pad on the other hand was given by Saiker. So the pear shaped pad term was given by Craddock and the retromolar pad was given by Saiker. And if the question has been asked that pear shaped pad, don't get confused with the retromolar pad because retromolar pad by Saiker and pear shaped pad by Craddock. Now what are the insertion, muscle insertions? If you look at, this is a retromolar pad, suppose this is a retromolar pad, right, pear shaped pad, which is here we have got this is the crest of the ridge. Now crest of the ridge posteriorly is the tendon of temporalis, laterally is the buccinator. As we know that towards the cheek is always buccinator. So suppose this is the buccal area, this is the lingual, and here we are going to have the tongue, right. So tongue is going to be here like this, right. So this is the area of the tongue, and buccally we have buccinator. So B for buccinator, B for buccal, remember this. So laterally we have got buccinator, and if we talk about medially, that means towards the midline, that means towards the tongue. So we will have the pharynx, right. So the laterally is the buccinator and medially is the pterygomandibular raphe and superior constrictor of pharynx, because medially we will have pharynx and superior constrictor of pharynx. So if the question is asked which of the following muscle is not an insertion for the retromolar pad, so if the option which is out of these four, temporalis, buccinator, pterygomandibular raphe and the superior constrictor of pharynx, will be the option. So the muscle attachment is again very important question, and another one we have is the main objective of the retromolar pad is the retention. So main objective is the retention. So retromolar pad helps in the retention of the mandibular denture. So this is the again one of the question that can be asked, right. So what is we are talking about the retromolar pad, right. So this aids in also the stability of the denture, also the retention of the denture, but if the option is retention of the denture, then this should be marked. Also help in the stability of the denture because it is resisting the movement of the denture base, right, because distal end of the denture is covering. Now 2/3 and distal end of the denture should cover 2/3 of the retromolar pad. So that means this is going to be the insertion of the denture, distal end of the denture, Let's mark it from some other color. So this is going to be the distal end of the denture. As we know that distal end of the denture is covers the 2/3 of the retromolar pad, right. So this is the retromolar pad. Now if we talk about retromylohyoid space, so this particular space is the retromylohyoid space, which is distal to the alveolingual sulcus. So this particular part is the alveolingual sulcus, right? This is the alveolingual sulcus, which is lingually. So this particular part is the alveolingual sulcus, and distal to it is our retromylohyoid space. So talking about retromylohyoid space, is distal to the alveolingual sulcus, and retromylohyoid space, let's just draw one more diagram over here in order to understand it better. Suppose these are the two premolars. We are talking about denture. This is the molar, right. So suppose this is the distal extension of the denture. So this is the distal extension of the denture, right. So retromylohyoid space will be covering this particular part, right. This is the retromylohyoid space. Now retromylohyoid space is bounded medially means towards the midline, and if we see towards the midline is our tongue. So soft palatal region, so that is the anterior tonsillar pillar. Then we have got posteriorly. What is posteriorly? Posteriorly is a retromylohyoid curtain. Now understand this, that first of all we have got retromylohyoid space, and behind this space, or I can say posterior to this space, is the retromylohyoid curtain, and posterior to retromylohyoid curtain is the retromylohyoid fossa, right. So retromylohyoid curtain, and posterior to it is the retromylohyoid fossa, right. Let's talk about once more. So first of all we have got the retromylohyoid space, which is posterior to the alveolingual sulcus. So this particular is the alveolingual sulcus. Then we have got, one second. So guys, this is our this is alveolingual sulcus. Posterior to it is the retromylohyoid space, and posterior to the retromylohyoid space is the retromylohyoid curtain, and posterior to the retromylohyoid curtain is the retromylohyoid fossa, right. So we have talked about medially, posteriorly, then laterally. Laterally means buccal area, towards the buccal area we have got the mandible. So laterally we have got the mandible and the pterygomandibular raphe. Which is the tendinous insertion of superior constrictor of pharynx and the buccinator. We know that Buccally, laterally means buccally to, buccally is always going to be the buccinator, and also this pterygomandibular raphe, it arises from the hamular process of the medial pterygoid and get attached to the mylohyoid ridge. So anteriorly we have lingual tuberosity of mandible, and posteriorly, inferiorly we have got mylohyoid muscle. That means inferior to it, mylohyoid muscle. Now we have all studied this in the surgery. Suppose this is the mandible, this part is the ramus, so this is the mandible. Here we have got mylohyoid muscle. So this is the mylohyoid muscle, Then here we have got sublingual gland. Above this we have got sublingual gland, above to the mylohyoid muscle, and below to the mylohyoid muscle we have submandibular gland, right? Submandibular gland. So guys, the mylohyoid muscle, above this we have got sublingual gland, and below this we have got submandibular gland, right? Now talking about the retromylohyoid fossa. Retromylohyoid fossa. We have already covered that. First of all is the alveolingual sulcus. Posterior to the alveolingual sulcus is our retromylohyoid space. This is the retromylohyoid space. Posterior to the retromylohyoid space we have retromylohyoid curtain, and posterior to the retromylohyoid curtain we have got retromylohyoid fossa. So the retromylohyoid fossa is the lateral throat form. Right? So this is the lateral throat form, which is also known as the lateral throat form. So lateral throat form is this particular part. One second. So this particular part is our okay, one second. This particular part is going to be the lateral throat form. So how deep it is? Again, we have to draw it again. Suppose these are the premolars, then we have got molars, then we have got molars. Now this is the distal extension of the body, this distal part of the denture, right? So this is the distal part of the denture, and this distal part of the denture is the lateral throat form, which lies in the retromylohyoid fossa. That is why we also call it the lateral throat form. Now how this lateral throat form is? Now class 1 if we talk about, which is the deep one. So class 1 is going to be like this. This is class 1. So class 1 is the ideal lateral throat form or ideal retromylohyoid fossa, which can accommodate a long and wide flange area. Then we have got 2, which is the moderate one. So this particular fellow is the 2, which is the moderate 2. So which is the moderate, half long and narrow as class 1 and twice long and narrow as class 3. So coming to the third one, which is the shallow lateral throat form. So shallow lateral throat form, the broad ends are 2 to 3 millimeters below the mylohyoid ridge. So this is the minimum length thickness. So guys, this is the class 3, okay. So this is the class 3, which is the shallow. So this is the border ends 2 to 3 millimeter below the mylohyoid ridge. Mylohyoid ridge, and this is the minimum length thickness. So now talking about alveolingual sulcus. Alveolingual sulcus. Okay. One more thing I wanted to tell you about the mylohyoid muscle is that, see, if we talk about the mylohyoid muscle, now this mylohyoid muscle, let me write it here again, mylohyoid muscle. What happens? This mylohyoid muscle, when we are swallowing, so because since it is present in the base of the floor of the mouth, so what happens, while during the swallowing, this mylohyoid muscle contracts, and when this muscle contracts, it raises the floor of the mouth, raises the floor of the mouth. Now what happens when it raises the floor of the mouth? Therefore, when the denture is overextended in the lingual flange area, so if suppose if the denture is extending and going deep into the mylohyoid muscle, then there is going to be the displacement of the denture, because this mylohyoid muscle contraction is going to raise the floor of the mouth. And if the denture is overextended, what will happen? It will push, it will raise the floor of the mouth and it will displace the denture by raising the floor of the mouth because of the contraction of the muscle of mylohyoid and causing the soreness due to the vertical forces, right. So when this mylohyoid muscle is contracted, the denture flange must be parallel to the mylohyoid muscle, right. So talking about alveolingual sulcus, we were at alveolingual sulcus, but before we proceed with the alveolingual sulcus, let's see what is mesenteric notch. So basically mesenteric notch is recorded somewhere here, okay. Let me write it, mesenteric notch. So mesenteric notch is due to the first of all, where it is attached, buccal to the crest of the mandibular ridge and the retromolar pad in the distobuccal corner. So it is formed by the action of mesenter on the buccinator. Action of mesenter on the buccinator. And it is recorded in the mandibular impression. So talking about alveolingual sulcus, now this is the alveolingual sulcus, right. This particular part is the alveolingual sulcus. So whole of this area is the alveolingual sulcus. So posteriorly it is the lateral throat form. If we talk about the posterior part of the alveolingual sulcus, posterior part is known as the lateral throat form. Lateral throat form. So we have got three regions of the alveolingual sulcus. Anterior region, which is from the lingual frenum up to the premylohyoid fossa. Then we have got the middle portion, which is from the premylohyoid fossa to the distal end of the mylohyoid ridge, and the third one is the posterior region. So posterior region is our lateral throat form. So posterior region of the alveolingual sulcus is the lateral throat form, which is also known as retromylohyoid fossa, which we have just now covered, which is also known as retromylohyoid fossa, right. So this is the posterior part of the alveolingual sulcus. Now the denture flange in this area particularly forms a typical S shape, typical S form of the lingual flange. Lingual flange of lower denture, right. Now in the people with a knife edge ridge, suppose if the person is having a knife edge ridge, people, there should be a broad surface area because we want to distribute the forces. So broad or the large surface area that should be covered by the denture to distribute the occlusal load, large surface area, right. Then there is no suction in the mandibular denture. Like maxillary denture, there is retention. While we are taking secondary impression, we get a very good retention in the maxilla, but we do not get in the mandible. So retention in the mandibular denture, it actually depend upon the maximal bone coverage. That means we have to include a large surface area. So that depend on the maximal bone coverage, right. See, maxillary denture, what happens if there is a good peripheral seal, if we have recorded PPS well, then there is going to be good retention. But in case of mandibular denture, while we are taking impression of a resorbed ridge, we hardly get the suction, we hardly get the good retention, we hardly get the peripheral seal. So in that case, retention of the mandibular denture is actually retention depends on the maximal bone coverage, right. So it basically depend on the stability, snowshoe effect, right. So large surface area should be covered. So the retromolar area should be covered. Retromolar area should be covered because we want to include the large surface area in order to get a stability, in order to get a retention in the mandibular denture. So the retromolar area should be covered, otherwise what will happen? Otherwise there is going to be resorption of the ridge, and there is going to be otherwise, let me write it, otherwise ridge resorption, and otherwise poor stability will also be there, right. So the most important factor for the retention is what? Most important factor for the retention is the peripheral seal, right. And secondary peripheral seal, and secondary peripheral seal is for the mandibular denture is the anterior lingual border. So, apart from retromolar area, first thing is retention is due to the in the mandible is due to the retromolar area, retromolar pad, which is going to provide the primary peripheral seal, and the secondary peripheral seal is due to the anterior lingual border of the denture, right? And retention for the maxillary, if we talk about retention for the maxillary, is due to interfacial surface tension. Interfacial surface tension, right? So, one more thing, one more important thing is that if the saliva is even and thin, if the saliva is thin and even, then there is going to be perfect adaptation. So, retention will come, and the denture base, we are talking about good retention, right? Let me write good here, good retention. One is the saliva should be even and thin, another one is the denture should cover large surface area so that the occlusal forces are distributed well and the stability, good stability will come, large surface area. So, closeness to the denture, to the soft tissues is due to the improved capillary action, right? So, the adaptation, good adaptation is due to capillary action. And one more very important point, thick pasty saliva is due to sympathetic innervation, sympathetic stimulation. And excessive ropey saliva, thick ropey. See, both we are talking about thick here. Thick pasty saliva is due to sympathetic, and thick pasty saliva is due to sympathetic, and watery saliva is due to parasympathetic, stimulation. And if we talk about excessive saliva, excessive thick ropey saliva, or if there is even lack of saliva, another term can be used as the xerostomia. If the patient is having xerostomia, if there is too much saliva, too much ropey thick saliva, or if saliva is not present, both the cases there is going to be decrease in the retention of the denture, right? So, thin mucosa, can be present in the maxilla, can be present in the mandible. If we are talking about in the maxilla, if we talk about in the mandible, in the maxilla, thin mucosa can be in the region of torus, palatinus and mid palatine raphe. And if we talk about in the mandible, can be due to mandibular tori or the mylohyoid area. Right. Now talking about the tongue. We'll be covering two classifications in the tongue. One is going to be the tongue size. Another one is the position of the tongue. The tongue size will be covering the house classification. The position will be covering the Wright's classification. Right. So, starting with the tongue size classification. So, the house classification on the tongue size. On the tongue size. So, class 1 is the normal tongue, wherein there is going to be normal development, normal function and sufficient teeth are present. Sufficient teeth are present. Class 2 is going to be, what happens in class 2, if you have seen any elder individual, older adult who is not wearing teeth, who has been edentulous for quite some time. So, when the teeth are absent for a long period of time, then you know what, the tongue tries to sit in the hole of the oral cavity because there is no restriction from the teeth, right. So, when the teeth are absent, from a long duration, from a long time, right. So, there is going to be change in the form and the function of the tongue. Change in the form and function of the tongue. Now, class 3 is when there is actually excessive large tongue. What happens when there is going to be a large tongue? This large tongue will cause the poor denture stability. It will not let the denture sit. It will not let the denture be stable in the mouth. Right. So, next one is our Wright classification. Which is based on the position of the tongue. So, how the tongue is positioned? Tongue position. Okay. So, class 1, again it has got 3 classes. Class 1 is what happens, suppose this is a mandibular teeth. Okay. So, what happens in class 1? When the tongue lies normally in the floor of the mouth is the class 1. Okay. So, when the tongue is actually, this is our tongue. This is the class 1. When the tongue lies in the floor of the mouth, it is the ideal. Class 1 is usually ideal. So, it is the ideal position when tongue lies in the floor of the mouth. So, slightly below the incisal edges. Slightly, as you can see, slightly below the incisal edges of the mandibular anterior. Coming to class 2. Class 2 is when the tongue is flat and broad. But what happens? Tip is in normal position. Normal position. So, the positioning of tongue is still normal. Coming to class 3, Wright classification based on the tongue position. What happens in class 3? This is the lower anterior, suppose. So, class 3 is when the tip of the tongue is actually curled. So, in case of class 3, you will find that tip of the tongue is actually curled upwards. So, this is a class 3. Tongue is retracted, depressed in the floor of the mouth, depressed in the floor of the mouth, and the tip is curled upward. Curled upwards. So we have covered two classifications for the tongue. One is the based on the tongue size, which is the House classification, tongue position, which is the Wright's classification. So House classification, tongue size. Tongue size we have covered. Class 1 is the normal, and class 1 for Wright also is the ideal tongue. So one is the tongue size, another one is the tongue position. Now that we have covered the high yielding points in the case history, let's go through the impressions. And the first impression we take is the diagnostic impression, and after that, if any pre-prosthetic surgery is required, then we go for pre-prosthetic surgery, and after that we take the primary impression. Right. So primary impression is taken with the help of a stock tray. Stock tray is a preformed tray. It can be of steel, can be of plastic. So primary impression, the clearance between the impression and the tray. So suppose this is the tissue surface, while we are placing a tray over here, right. So this is a tray. The prime space between this is the tissue surface, then we have got the tray, right. So between the space or the clearance between the primary impression, between the stock tray and the ridge is usually 5 millimeters, right. So the clearance between the ridge and the stock tray. See, you have to read the question carefully. If the question is asked between the ridge and the stock tray, then it is stock tray. Then it is 6 millimeter. Minimum of 5. It is 6 millimeter. Minimum it should be 5, right? And for alginate, this clearance is 3 millimeters. So primary impression, the materials in case of complete denture, we use it impression compound, which is usually used for an ideal ridge, that is a well defined ridge. Then alginate in case of deep undercuts, and impression plaster in case of flabby tissues. Right. So these all are the material which we use for taking primary impression. Now coming to the theories of impression, we have got theories of impression. 3 theories: muco-compressive, wherein while taking the impression, muco means mucosa, compressive means we are putting pressure on the mucosa. The second one is the mucostatic. Static means there is no pressure which is applied. Muco means on the mucosa. Because since there is no pressure which is applied, so it is also known as passive impression. The third one we have is the selective pressure technique or selective pressure theory. Selective pressure, as the name suggests, selectively we are putting pressure. So pressure in the stress bearing areas and relief in the relief areas. So the first one we have is the muco-compressive. As the name suggests, we are going to compress the mucosal tissues, and it was given by Carl Jones. Now you can remember it. C for compressive and C for Carl. So it is in form of functional and displaced form, because since we are applying pressure, so the mucosa or the soft tissues are displaced in this. Then the material which is used for the mucocompressive technique, so the materials are impression compound, right, which is the most important, and we have got waxes, then soft liners, then also elastomers, then ZOE paste, right. Next, coming to second one is the mucostatic. Mucostatic, also known as passive impression, and as the name suggests, muco means mucosa, static means there is no pressure which is applied, and that is the reason that it is also known as the passive impression. And it was first proposed by Richardson and popularized by Henry Page. So you can remember it, P for passive and P for Page. Then there is no border molding which is required for mucostatic, because we are not putting pressures. Since we are not putting pressures, so an oversized tray is used. So oversized tray is used, right. Then the impression is taken in the relaxed state. Now one more thing which I want to tell you is that, which I forgot to tell you, in the mucocompressive, what happens, since we are putting pressure on the tissues, right, in mucocompressive we are compressing the tissue. Since we are compressing the tissue, so there is a constant pressure, and because of this constant pressure which is applied on the tissue, because of that there is going to be increase in the ridge resorption. Right. So there is going to be increase in the ridge resorption in case of mucocompressive. Talking about mucostatic, since there is no pressure, we are taking impression in the relaxed state, and because of that there is going to be the poor peripheral seal. And because of the poor peripheral seal, because the seal, proper seal is not provided because of poor seal, the peripheral seal is the main component of retention, right. So the primary retention is due to the peripheral seal, and secondary we have talked about the anterior lingual, right. So if there is not proper peripheral seal, if there is a poor peripheral seal, because of that there is going to be the poor retention of the denture. But on the other hand, in the mucostatic there is going to be the poor retention, but on the same way, on the same side there is going to be good stability. So though the retention is poor for mucostatic or the passive impression, but the stability is good, and the example for this is the impression plaster, which we use for recording the flabby tissues. Impression plaster, this is same like a gypsum product. So beta hemihydrate crystals, same like how we mix the plaster of Paris, the same way we mix it. So coming to the third one we have is the selective pressure technique. In the selective pressure theory, there is going to be the pressure which is applied in the selective area, right, as the name suggests, applying pressure selectively. So pressure in the stress bearing area and non pressure, or we are giving relief in the in the relief areas or non-stress bearing areas, relief areas. So that is the mid-palatine raphe usually. So the material of choice for selective pressure technique is zinc oxide eugenol, impression paste, or the medium body elastomers. Medium body elastomers. Right. So this selective pressure technique, we are putting pressure selectively everywhere on the whole of the ridge. Pressure is not uniform. We are putting pressure on the stress bearing area, we have covered in the anatomy. Non-pressure in the relief area, that also we have covered in the anatomy. The selective pressure theory was introduced by Wilson and advocated by Boucher in 1943 and introduced by Wilson in 1920. So this is about the impression theories. We have covered mucocompressive, Carl Johns, CC is there, mucostatic, which is the passive impression, then Page, and then selective impression by the Boucher, which is the complete denture book, which we all know. So what happens when we are taking too large tray? So first of all, we check the tray size in the patient. What happens when we are not checking the tray size, and or we don't know how to check the tray size, and we are taking impression? So if there is a too large tray we take, what happens? There is going to be the distortion. There is going to be distortion of the tissues around the border of the impression. Distortion of the tissues around the borders of the impression. Because the tray is too large, definitely the borders are going to get distorted, right? So borders of the impression. What happens if the tray is too small? What happens if the tray is too small? Then the tissues will not get recorded. Why the tissues will not get recorded? Because the border tissue will collapse. Border tissues will collapse inward, inside, because the tray is small, into the ridge, and because of that there is going to be reduced support of the denture. So if the tray is large, then there is going to be distortion around the borders, because tray is large, border will not get will not correctly or accurately recorded. If the tray is small, the border tissues will collapse inward into the residual ridge, and there is going to be reduction in the support of the denture. Since we are talking about the materials, impression materials, let's talk little bit about the materials. Even though we will be covering impression materials in the dental material in detail, but the impression materials are classified majorly into two groups. So the impression materials are classified in inelastic, and we have got the elastic impression materials, right? So inelastic impression, as the name suggests, inelastic, they are not elastic. So the impression material become rigid and it get fractured, or even it get distorted when it is removed from the undercuts. So they are not compressing the tissues. So inelastic materials can be impression plaster, or also it can be ZOE. So all the mucostatic impression materials will come under inelastic. Elastic means the tissues are, the impression is elastic. So it is going to be the mucocompressive kind, that is the elastomers. So all the elastomers, right, like polysulfide, then we have got condensation silicon, then we have got additional silicon, then we have got polyether. So all the elastomers will come under elastic impression materials, right. So all these polysulfide, condensation silicon, addition silicon, they are hydrophobic. Rest of the elastomer, we left with only one, which is the polyether, which is the hydrophilic. So hydrophobic means it is going to repel the water if we are pouring the cast. There may be bubbles which can come. So for that we are adding surfactant. Surfactant is added to hydrophobic. Materials, so that the bubbles won't come. And in fact the disinfection of the hydrocolloid is also again asked. Disinfection of hydrocolloids, we have got reversible, irreversible. Reversible hydrocolloid is the agar-agar, irreversible hydrocolloid we have is the alginate. So we disinfect via 1:10 dilution of the bleach, which is the household bleach, or we can use the iodophore, or even phenols can be used. But remember that when we are using these things, it should be, time should be less than 10 minutes. It should not exceed more than 10 minutes. That we know. Now talking about impression plaster. Impression plaster is, as we know, it is a kind of a gypsum product, type 1. We will cover in the dental materials that gypsum product are classified into 5 types. So impression plaster is the type 1 or gypsum product. So impression plaster is the type 1 gypsum product. Now what happens? Because cast is also made up of gypsum product, impression is also made up of gypsum product. So in the impression plaster there is something known as potato starch, which is added. So what happens? This potato starch will like separate the cast from the impression. For separation of cast from impression, right. In the hot water bowl we are going to put the impression plaster. The starch in the impression plaster swells up and breaks the impression, and thereby we separate the impression from the cast. Then also we have got impression compound, which is our reversible thermoplastic material. That means we require water. So the water bath temperature is 64 degrees Celsius. Then the technique is wet kneading. That means we put it in the water bowl and then like a dough, how we mix a dough, like that we mix it. So talking little bit more about the impression. What are the objectives of impression? So the objectives of impression is retention, stability, support, and the preservation of the structures. That's it. Very simple objectives, right? So the objective is retention. Retention is the resistance to the displacement away from the tissue surface. So it is a mucosa borne phenomena. Mucosa borne phenomena. So it is resistance of displacement. Resistance to displacement away from the tissue surface. Right, then we have got support. Second one we have is the support. So support is when we are talking about resistance to the occlusal forces. Occlusal forces, right, in the vertical direction. So this is a bone-borne phenomena. Or we can say snowshoe effect. That means more the surface area, less is the load, right? How we walk in the snow. While during snow, how we walk is large surface area, right? So that gives us support. Third one we have is the stability. So stability is the resistance to the lateral forces, lateral shifting or the anterior posterior shifting. Then the last one is the preservation of the remaining structures. Then very important points that can be asked is again the atmospheric pressure. This is a straight away point. Atmospheric pressure, or also known as emergency retention force, emergency retentive force, which is going to hold up the maxillary denture, right? Or the temporary restraining forces, temporary restraining forces. So this is 14.7 lb per square inch, right? Very important. This has been asked couple of times in different exams. So the atmospheric pressure is 14.7 lb per square inch. Also we have got a couple of things with the number 14. So 14 centimeter square is the mean denture base area. For the edentulous mandible, right? Then we have got weight of atmospheric pressure, which is also 14. So 14, just now we have covered 14.7 lb per square inch, which is our atmospheric pressure. So weight of atmospheric pressure. So we have got two things to remember from 14. One is the mean denture surface area, the mean denture base area for the mandible, and another one is the weight of the atmospheric pressure. This is about the mandible. The edentulous area, mean denture base area for the mandible is 14 centimeter square. What about the mean denture base area for edentulous maxilla? It is 24. See, very easy to remember, 24 centimeter square. So for the mandible it is 14 and for maxilla it is 24. So guys, we'll cover the CD into three parts. From second part will be starting from the residual ridge resorption and the jaw relation and articulation, and the third part will cover rest of the CD. So let's just revise whatever we have covered till now. So we have covered case history. In the case history, first of all, steps are not that important. So clinical steps and the lab steps, you know that types of 4 type of patient, ideally, moderately, substantially compromised, severely compromised. Mental attitude is again important. So we have got the philosophical, which is the ideal attitude of the patient, and exacting, where the patient find fault, he want exact treatment. Hysterical, bad previous experiences makes the patient hysterical attitude. Indifferent, because of the family pressure the patient has come to the dentist, the attitude is different. Again, revised House classification: ideal, submitter, reluctant, indifferent, resistant. Shape of the palatal vault: U-shaped palatal vault, which is the most favorable. Then flat palatal vault, which is going to resist the downward, but it is going to produce the dislodged rotational or lateral movements or forces. Right, and V-shaped palatal wall, which is the least favorable, right, which is not good for the retention of the denture. Then bony undercut maxilla, either it can be relieved or we have to remove it surgically. If it is present in the anterior ridge area, or if it is present lateral to the maxillary tuberosity, then it can be relieved in the denture. And if it is relieved into the denture, it is going to provide the primary support. That means we have talked about firm and bony swellings. They are going to give the primary support. So the maxilla, it can be relieved or surgically. But if we talk about in the mandible, we have to surgically remove it. So there is no other way out, we have to surgically remove the bony undercuts if are present in the mandible. Again, same goes for the tori. If the tori is present in the mandible, it has to be removed. There is no other way out, then we can keep it. In the maxilla, we can keep it or we can remove it. When we have to remove it, if it is extending till the PPS area, if it is interfering with the speech, or if it is causing the poor denture stability. Right, and then tori is present in the maxilla in the middle of the hard palate, in the mandible, in the lingual side of the premolars. Then the large tuberosity, again bony and firm swelling if it is present, then the stability, it is going to provide the primary stability to the denture. Coming to anatomical landmarks, maxillary, stress bearing area, primary and secondary. Primary, we have got all the slopes. So the primary, why do we call it primary stress bearing area? Because there is going to be least resorption, and it is seen in the horizontal slopes of the hard palate, all the slopes, and the posterior lateral slope of the residual ridge. Secondary, we have got 3 things: crest of the residual ridge, rugae, and the maxillary tuberosity. Then coming to the supporting areas, we have got hard palate, rugae, posterior lateral slopes, maxillary tuberosity, and the relief areas when we are not supposed to put pressure by the denture. These are the incisive papilla. Then we have got the cuspid eminence and the mid palatine raphe. Then the next one is the number of frenum which are present in the maxilla. There are 3, in the mandible there are 4. Then coming to mandibular support area is the buccal shelf area and the residual ridge area, right. So the buccal shelf area, again very important. Then relief areas, we have got the crest of the ridge, mental foramen, genial tubercle, torus mandibularis. Limiting structures both in the maxilla mandible are the labial frenum, labial vestibule, buccal frenum, buccal vestibule, and in the maxilla hamular notch, fovea palatina, PPS. In the mandibular, lingual frenum, alveolingual sulcus, retromolar pad, and pteriomandibular raphe. Support to the maxilla is usually by the palatine bone and the palatine process of the maxilla. Buccal frenum is going to do the buccal frenum is pulled in a forward direction by the orbicularis oris, RR. I'm sorry, RR you have to remember, right, and buccinator backward pull, BB. Then we have got the hamular notch. Hamular notch is the notch or the depression present distal to the tuberosity. So distal part here, and it is going to mark the posterior border of the denture, maxillary denture. So fovea palatini, these are the mucosal gland openings which are present posterior to the hard palate, and the denture should extend beyond 1 to 2 millimeter to the fovea palatini. That means denture will end behind the fovea palatini. Then we have studied the classification of the soft palate, ideal type 1, which is more than 5 millimeter, which is almost the horizontal. Then we have got 1 to 5 millimeters, which is the type 2, and the angle is 45°. Type 3, which is poor for the retention, and less than 1 millimeter of the tissue support is there. Then amount of posterior tissue will give us the PPS area. More the PPS area, more is the retention. PPS area is classified into two types. I mean, it is composed of two parts: the posterior palatal seal area and the pterygomaxillary notch, or the pterygomaxillary seal area, or the hamular notch. The vibrating line, anterior vibrating line, which is cupid bow shape. And we have also studied that the two method to measure the anterior vibrating line, Valsalva maneuver or A in a short vigorous manner or short vigorous burst. A is so posterior vibrating line, it is in an exaggerated manner. So we have covered that posterior vibrating line, the most distal extension of the denture base is marked by the posterior vibrating line, PPS postdam, which is very important for the retention point of view. And while recording the PPS, the head of the patient should be tilted downward by 30°. Then we have studied the technique of recording the PPS: conventional, fluid wax, and arbitrary scraping of the master cast. Conventional approach with the help of a T burnisher, fluid wax technique with the help of mouth temperature waxes. In that we have the mouth temperature waxes such as Iowa wax, Correcta wax number 4, and HL physiologic paste. Then the glossy surface in the wax shows the tissue contact. On the other hand, in the green stick, the glossy surface show no tissue contact. So arbitrary scraping of the master cast, width and depth. So width is going to be least in the hamular notch area, and most is distal to the mid palatine raphe, and depth is going to be least inside the least is going to be mid palatine raphe, because we cannot put pressure on the mid palatine raphe, and it is going to be most in the hamular notch area. Then there is improper PPS. The most common cause of the failure of seal is due to the under extension of the PPS or the post dam, right. Then we have studied the under or over post damming. Then mandible buccal shelf area we have studied, which is the supporting area, relief areas, limiting structures. We have studied about the retromolar pad area, and the main objective is to provide the retention, and we covered till the 2/3 of the retromolar pad area. And we have also studied the muscles attachment, right. Then we have studied the retromylohyoid space, and retromylohyoid space, mylohyoid muscle, when it contracts, it raises the floor of the mouth. So whenever we are marking the distal border of the denture, it should not be overextended, otherwise the patient will have difficulty in swallowing, and patient will complain of pain. Then we have studied the retromylohyoid fossa or the lateral throat form, 3 kinds of lateral throat form: alveolingual sulcus, and the alveolingual sulcus posterior border is the lateral throat form itself, which is the retromylohyoid fossa, which is S in shape. Then the retention of the mandibular denture is due to the maximal bone coverage, which is the stability. Then most important factor for the retention is the peripheral seal, right. Then we have studied the we have studied the excessive thick ropey saliva or lack of saliva will reduce the retention of the denture, right. Then we have studied the classification of the tongue based on the size and based on the position. Then we have studied the clearance between the ridge and the stock trays 6 millimeters, theories of impression, CC, mucocompressive, Carl-Jones, mucostatic, passive impression, Page, and selective pressure theory by the Boucher. And we have studied the impression materials little bit. Impression materials will cover in the dental material. Also objectives of impression: atmospheric pressure, which is 14, and which is the mean denture base area for the edentulous mandible is also 14 centimeter square, while for maxilla it is 24 centimeter square. So that is about the part 1 of the complete denture express revision. I hope that you guys are benefited from the videos, you guys get good marks. I know that you are going to score well in your exams and you have understood it. So if there is anything way I can help you out, feel free to comment in the comment section below with your preparation. I'll do my best to help you out for your exam preparation. All the best to you, and the continuation video will be published in the, you can check out in the playlist, you will find in the playlist. So guys, all the best, prepare well, see you soon, take care, bye bye.